So friends, we shall discuss about the NEET SS last 2022 questions. And when we come to the question paper, if you go through each year, you can see in our app, if you go to the each year question paper, the neuro part is getting tougher each year. Even NEET that is happening, some questions it comes core neurology, it's DM level questions, but out of all the INIS exams, this was seemingly for me very tough questions. Not all, but not all questions are tougher. We were able to get these questions from many of our students and friends who collected the questions. So some of the questions I was not able to get the entire options. I was not exactly got the root of the question, but I got again, like I discussing some questions, like I think that this might have been the question. So there may be some changes as usual in any recall session. And if you see into the question pattern, we got around 53 questions, and of these 53 questions, there were actually some 15 questions, around 15 questions, really tough questions. And there has been question coming from this question had been coming from directly from Bradley. Even some figures they kept directly from Bradley. So that doesn't mean that you have to go through Bradley. You cannot even study and remember entire Harrison and deliver it. So you need to have certain concepts. Even though there's 15 or 15% questions or 25% questions which are tougher, you can able to solve a little bit of them. And some questions, if you feel like it is very tough, that will be tough for everyone. So you cannot burn your heart for that. And if you take into the entire question distribution, this was how the distribution was. If you see, the majority of questions this time came from epilepsy, movement disorder, dementia and stroke. Even though there are questions coming from the stroke, the pattern of questions were little bit different from what it used to be previously. So you will start with the muscle. I kept this order even though the majority of questions come from epilepsy. I didn't keep the epilepsy as a first discussion just because the questions which come from the muscle and NMJ were very tougher. And you see, if you see, this was the first question I want to discuss is a pathology slide of the muscle biopsy is shown below and what is the probable diagnosis. This was a question whether it's a muscle dystrophy, inflammatory myopathy or a denervation and renervation. What is a possible option? This I feel is a very tough question because first of all, many of you might not have gone through muscle biopsy in detail. This actually muscle biopsy is a DM level question, pure DM level question, especially this option. If they are given some dermatomyositis or something like that, it might have been a little bit easier. But this is pure DM level question. And when you, if suppose you are going to start your exam, you got this question as a first question, you will get stuck there. You will think that, okay, this paper is going to be get tougher. And this is something which I have not gone through, so they may ask certain difficult questions. So that will ruin your confidence. So that should not happen. Even if some tough question come, you should leave it. And there will be some easier questions coming later. Then come back and keep your mind calm and then go and answer, you will get it. That is why I kept this question in the first only. And that is why I kept muscle, even though only 4 questions asked, I felt all the 4 questions were difficult in muscle. And so, this is actually a biopsy has been given and they had shown a biopsy and asking what is a possible diagnosis. Really tough question. So this is a normal muscle biopsy. You see certain dark colored muscles and certain light colored muscles are there. So these dark colored ones are actually type 2 and light colored ones are type 1 muscles. So you know that there is type 1 muscle and type 2 muscle, and this is something known as adenosine triphosphatase stain at pH of 9.4. This is something as a normal muscle. You see there is a random pattern. That means you see there are certain darker ones and certain lighter ones are randomly placed. You won't see a particular pattern there. There are some darker ones coming here, then lighter ones coming. The random arrangement of these darker ones and lighter ones, or random arrangement of type 1 and type 2. This is known as a normal mosaic pattern or looking like a checkerboard pattern or mosaic pattern. This is a normal muscle. You see this, each of these are the muscle fiber. Each muscle fiber is made up of lot of muscle myofibrils. So each muscle fiber is surrounded by an endomysium. Then many muscle fiber forms is covered by a perimysium and there is endomysium. Outside to that there is an endomysium. So this is how the biopsy looks like. So you have a normal checkerboard or mosaic pattern. Keep in mind this mosaic or checkerboard pattern where type 1 and type 2 are randomly arranged. So what happens in denervation, reinnervation? In denervation, reinnervation, what happens is, these are the muscle fibers. Some of these muscle fibers, during the denervation, some of these muscle fibers become atrophied. And these muscle fibers become smaller and get angulated in between the normal fibers. That is known as angulation. That is the first stage you will see is an angulated appearance. That is something which you see in a denervated muscle fiber. Then what happens is, when there is atrophy, I told that each muscle fiber is made up of lot of myofibrils. And in this myofibrils, these are kept together by intermyofibrillar network. So, each muscle fiber contains lot of myofibril and it is kept together by intermyofibrillar network. So, when there is a denervation, this intermyofibril get damaged. So, what happens is, they will form something known as a target cells, where you have a less strained central area and slightly higher strained outer area, then slightly less higher strained outermost area. So, that looks like something like a target sign. Here you can see that this is a target sign, where you can see that central area, there is a hypointense or less strained central area and surrounded by the brighter strained area. This is because of intermyofibrillar network changes. That is also seen in denervation. Then, you know that each your motor unit is supplied by a particular anterior horn cells. So, each motor unit actually supplies only one type of fiber. So, type 1 fibers will receive innervation from a particular motor neuron which innervate that, or the nerve twig which innervate only type 1. There is another nerve twig which innervate only type 2. Okay. Suppose there is a damage happened. This is type 2. So, suppose there is a damage happened to one of these muscle twigs or denervation happened. So, what happened? Only that nerve twig which is supplying the group of muscle, that will be atrophied. So, that means that this group will get atrophied. That is something what is known as group atrophy, when there is a group of fiber supplied by same nerve twig. So, that damaged nerve twig, one group of muscles will be atrophied. That is known as group atrophy. So, now after atrophy, there is a reinnervation is happening, and this reinnervation is going to innervate the same muscle fiber only. So, if a nerve twig innervating a type 2, it will reinnervate and innervate again the type 2 only. So, the type 2 fibers will get more number, while the type 1 which is not getting innervated, they will go down. So, that is known as fiber type grouping, where you will lose the normal checkerboard pattern, where you have random arrangement of dark and light stain. The random arrangement of type 1 and type 2, that will be lost. So, angulation or angulated appearance, target fibers and group atrophy, and fourth one, when reinnervation happen, they will produce random pattern is lost, that is loss of checkerboard or mosaic pattern. That is classically seen in denervation, reinnervation. Here you see in the picture, this is actually exact figure, almost exact figure. That is what I came to know. And it is actually from Bradley, directly from the Bradley. You can see that you can see the darker fibers going together. Here the lighter fibers going together. The random pattern is lost. This is lack of or the absence of normal checkerboard pattern. This is classically seen in denervation, reinnervation. Okay. This is a really tough question. This is even a DM level candidate may be difficult to answer this question, because this is something which is you might not be familiar with. That is why the INI each year, the neuro question standard is going sky high. So, that is a denervation, reinnervation. So, this is what is you are seeing is another type, not the classical ATPase stain. I am not going to stains and all. So, this is again you can see certain fibers are atrophied here in this area. You see into this area, there is atrophy of certain fibers there, that is atrophy and angulation. Some of the tissues are, the fibers are going in between the normal looking these fibers. So, that is known as angulation. Here you see the target sign. So, in myopathy, what happens is certain features are there, necrosis of muscle fibers, then internalization nuclei. I am not going into all those things, because this muscle biopsy itself is a detailed topic, which we will include in one of our MCQ discussions. Somewhere we will discuss about muscle biopsy and nerve biopsy later, because now they start asking these questions also. So, coming to the next question, which is which of the following is anti-myotubular myopathy? Again, this is a difficult question, but if you use some logic, you can answer. So, you see that there is from the question you are sure that the options are given, other two options are there, all they are drugs. I do not know exactly what are the options given. So, that means that there is a drug induced myopathy. So, the question is which among the following affect the myotubular system. So you know from the options that colchicine is a drug which is acting on the tubulin. So it should be the answer. That in that natural way, if you go, you can answer it. If you know that colchicine mechanism of action, you might be able to guess it, not exactly answer, guess it. Again, the drug-induced myopathy can be classified later. Now that this classification also come up, and so it is actually I got it from some articles. You can divide the myopathy based on the mechanism of action, the drug-induced myopathy mechanism of action. You can divide into necrotizing myopathy with rhabdomyolysis. This is a classical one in statin, niacin, fenofibrate. Then immunophilins which destabilize the membrane, that is cyclosporins and dacromycins. Anti-myotubular myopathies which act on the impair the liposomal trafficking by acting on the microtubules which act on the tubulin, that is colchicine and vincristine. Then lysosomal storage myopathies which are acting on the cell membrane organelles which act on the are called chloroquines, HCQs, amiodarone. Mitochondrial myopathies act by pseudovidin, entecavir and toluidine. Then drug-induced inflammatory myopathies where statins is a classical drug. Immune checkpoint myopathies which we have discussed in one of our discussions. They are nivolumab, pembrolizumab, all these drugs. Ipilimumab. Then other toxic myopathies like steroid myopathies, amitriptyline, omeprazole, alcohol, cocaine. Actually, it is very difficult. Again, this question, I feel it is tough question, but if you use little bit logic, you may be able to guess the answer. I am not telling you, you may be able to answer. You may be able to guess the answer only. So next question is again little bit tough, but to arrive at a diagnosis is not a tough thing because we have discussed this myopathy. But this is like the question is a 6-year-old boy with hyperlaxity of joint and proximal weakness. So that means proximal weakness. We have discussed the limb-girdle pattern of weakness, that is a proximal weakness, the classical myopathies, and the option is all LGMDs are there. And this is hyperlaxity of joint. So you know that we have discussed about hyperlaxity of joint, which is seen in the collagen related myopathies. We have discussed about the Bethlehem myopathy. We have discussed about all those things in our discussion on other myopathies. But this is a new classification, D1, D2, D3 and D5 we are given the option. This you can answer only if you know the new classification. This is also, for me, I felt it is a really tougher question as the option is given like this. If they are given option like Bethlehem myopathy, hemorrhagic all those options are given, then it might have been easier because you know that it is Bethlehem myopathy. But this question, they want you to know the new classification. So Bethlehem myopathy or LGMD D5 collagen 6 related myopathy is allelic to your Ulrich congenital myopathy. Ulrich is a severe form. Both of them affect collagen. They may have keloid, they may have joint laxity, especially distal joint laxity with an LGMD-like presentation. And contracture is also very common. So that is Bethlehem myopathy. Again, it is a difficult question. You can answer it only if you know the latest classification, dividing into autosomal dominant, autosomal negative. I mean, autosomal recessive, autosomal dominant are LGMD 1, 2, 3. You see here, Col6A1. So when there is hyperlaxity of joint, you know that it is something which is affecting the collagen, and you know it is Bethlehem myopathy. But the option they made it very tough, really tough by keeping it. So all the 3 questions till now we discuss are very tough questions. So that is why I kept muscle in the beginning, because you need to start with tough questions. Immune mediated, what I mean is you mean to start the discussion when about tough questions only, but when you are going to answer your exam, it is always better to have the easier ones first because it will boost your confidence. The next question is immune-mediated necrotizing myopathy among the following which is not true. I don't know exactly if this was option. This is what I got. But even though the question looks little bit confusing, but the answer is very easy. You knew that we have discussed that any immune-mediated myopathy there is association of cancer is there. You should be following up the patient for minimum 2 to 3 years for malignancy workup, because even though initial evaluation negative, later they may turn up to be a malignant lesion may be found out. So evaluation of cancer need to be done. The Q is not true. There is a negative question. The major point of such questions you need to assess is whether it is a positive question or negative question. Here the option is not true. So this is a true statement. So this is not the answer. This is a true statement. So this is not an answer. The second is monotherapy of steroids is associated good response. Biopsy shows minimal infiltrate and muscle fiber necrosis. I don't know what is the fourth option. Actually, the immune-mediated necrotizing myopathy, even though the term has immune-mediated necrotizing myopathy, it is a necrotizing but less inflammatory infiltrate, which we have discussed in our module. If you have gone through the module, you will be able to answer it. So that is actually true statement. Again, that is a true statement. The question is not true. So that is not the answer. Monotherapy with steroids is also a good response. Actually, monotherapy with steroids can have response, but majority of the patient with immune-mediated myopathy may need second line therapy. That also we have discussed. So this is necrotizing myopathy. They have aggressive and severe weakness with necrosis and very high CPK, but biopsy shows necrosis and no inflammation. That also we have highlighted in our presentation. Here are three types: HMG-CoA, anti-SRP and antibody negative necrotizing myopathy. And you see the association with cancer is weak association with HMG-CoA and no malignancy association anti-SRP, but antibody negative has the highest association with malignancy. It is negative for antibody because we don't know what is exact antibody. We don't have tests to identify that. Later, new classification will come up once your testing systems improves. You will find out some new antibody, then you will find out the test for that, then you will pick up it. Till now, we have three classified into three: HMG-CoA as anti-SRP and antibody negative. And see here, this is something which we have discussed. All patients need cancer screening in any inflammatory myopathy, and it should be followed for 2 to 3 years. Later, they may develop malignancy. Most need second line drugs like an inflammatory myopathy. So, most of the inflammatory myopathies, including the necrotizing myopathy, will require second line drug. Especially necrotizing myopathy requires second line drug. Necrosis with minimal inflammation is a classical feature of necrotizing myopathy. So, the answer here is which among the following is not true. Monotherapy with steroids has good response, I think, is not true statement. And again in exam, if such a the fourth option and third option you have to compare, because it is not as a good statement, is a vague statement. So, if there is one more option which is better answer, you can go for that. But from the available option which I got, the answer is, the best answer is box. Monotherapy with steroids is not with a good response is a not a true statement. Majority requires second line therapy. So, that was a muscle session. Muscle 4 questions, all 4 were difficult. I felt the easier question was necrotizing myopathy. So, I will score like 3 out of 4 maybe answerable. Necrotizing myopathy is easier. And even the hyperlaxity, you know that is Bedley myopathy. If you have gone through the modules, you will be able to answer that. But the options, there is no Bedley myopathy. The option there was LGMD, latest classification. So, that added on the confusion. So, muscle, all the 4 questions are tough. I will score 3 out of the 4 is tough. 1 question may be tougher. May be able to answer. Remaining 3 were tougher for me. Then coming to NMJ again the questions were DM level maybe over that, maybe higher than DM level. Very tough question. Only 2 questions, both are very tough. The first question was from SFEMG, single fiber EMG. Many of you might have heard of that, but I'm damn sure many of you might have not have read the details of that, because single fiber EMG is a question which is asked during the DM exam for your final year DM. That is one of the major questions they can ask in the practical as well as theory. So, what is SFEMG? SFEMG, you need a special type of needle, and that special needle you will insert just like EMG, you are going to do insert it, and what you are going to find out is that when the action potential travels distally along the nerve, this is a muscle, and when the action potential travels distally along the muscle, all the muscle fibers supplied by the same, all the muscle fibers in the motor unit supplied to the nerve will be excited at more or less in the same time. All the muscle contains lot of muscle fibers. All the muscle fibers innervated by the same twig. One twig or one anterior horn cell will innervate one motor unit. So, all the muscle fibers will be activated at the same time. So, if there is a variation in activity, there is a first, second, third and fourth motor fiber of the same motor unit is sitting there. You have activation of first, then later second, then third, then fourth. That means that all are not activating together. That is the abnormality which is picked up by the single fiber EMG. That abnormality, when there is a variation between the adjacent muscle fiber from a same motor unit, is known as jitter. So, when jitter is present, that is abnormal. Okay, that is abnormal jitter. So, it reflects a variation in NMJ transmission. If each motor fibers are not activating at the same time, that means there is abnormal connection through the nerve. Either the nerve is abnormal or the neuromuscular junction is abnormal. Okay. So, jitter, even in myasthenia, if it is the normal powered muscle, you have weaker muscle and normal muscle. The weaker muscle may show abnormality in RNS, but the normal muscle may be showing no abnormality in RNS. So when the normal muscles will show abnormality in SFEMG. So the importance is normal jitter in weak muscle rules out myasthenia. When you have a normal jitter in a weak muscle, that rules out myasthenia. So, but SFEMG is not sensitive, not specific. Why? Because when each muscle fibers are not activating at same time, that means either it can be neuromuscular junction problem or it can be nerve problem. So, it can be abnormal in myopathy, it can be abnormal in neuropathy. So, that is not specific, but it is sensitive. In ocular myasthenia, SFEMG can be normal. So, it has to be done when you have a strong suspicion, when all other tests including RNS is negative, but you still suspect a myasthenia, then you go and do it. Otherwise, you will land up in trouble, because a myopathy or neuropathy can have abnormal jitter. Second is, in ocular myasthenia, you can have in spite of having myasthenia, you may have a normal SFEMG finding. So, coming back to the question, which among the following is correct? Normal muscle in normal jitter in a weak muscle exclude myasthenia. That is correct statement. Normal jitter in orbicularis oculi excludes ocular myasthenia. That is wrong statement. Why? Ocular myasthenia can have normal jitter. Abnormal jitter in a weak muscle confirms myasthenia. That is also wrong. Why? Abnormal jitter in a weak muscle can be due to myasthenia, can be due to myopathy, can be due to neuropathy. If you have clinical suspicion, you have other tests negative, then last you go for SFEMG. SFEMG is never the first investigation, because you will end up in trouble. So, if a normal jitter in a weak muscle and suspected myasthenia, if it is normal, then it is not myasthenia. That is a correct statement. So, answer is A. So, that is clear. So, SFEMG is never specific. SFEMG is sensitive. When you have clinical suspicion of myasthenia and all other tests are negative, then you go for SFEMG. If a normal jitter you are getting, point number 1, if a normal jitter you are getting from a weak muscle, that rules out myasthenia. But it can be abnormal even in neuropathy and myopathy. It is not specific. Ocular myasthenia, it can be normal. To be done only in a suspected case when all other tests are negative, including RNS. So, this question was very tough for me, because for the MD level exam, this is really tough. So, that is also a very tough question. Then coming to the next question, a limb-girdle congenital myasthenia syndrome with tubular aggregate. This is actually very difficult for me also. I went and searched in the net and I got this from a journal that GFPT1 is a congenital myasthenia syndrome with tubular aggregate. Okay. So, GFPT1 is a key enzyme in exosomal biosynthesis pathway, and this is actually, I felt like it is it is a tough question, because there is a lot of questions you can ask from congenital myasthenia syndrome, but they picked up this question, which is very, very tough. Leave these two questions, especially the second one. I don't think majority may be able to answer this. I don't think this doesn't matter also for exam, because when you get a very tough question, when all the students who is attempting for the exam cannot answer it, there is no need of no value for that question. So, finish the muscle and NMJ. Both of these topics are really, really tough. Altogether 6 questions asked. I believe that both the questions NMJ was tough, and 3 out of the 4 questions of muscle was tough. So, I believe that 5 out of the 6 questions are really, really tough. Then coming to the next question, next session, that is peripheral now. There are 4 questions came from peripheral now. Actually, it was not that tough. GBS patient admitted hospital 1 week, which of the following predicts functional independence at 6 months in GBS? This is something which we have discussed, and it is in fact a little bit easy. We have discussed during the session, when you have diarrhea at onset, when you have severe weakness, ventilator dependent, fast progression, the likelihood of progression, likelihood of recovery is also less. So, it is as simple as that. Severity of weakness is a major factor, common pulmonary nerve latency, amount of protein, all these doesn't matter. So, this is something which we have discussed, all these things, these 3 things we have discussed. And age more than 60, low distal CMAP amplitude, severity of illness, rapid progression and need of ventilator support, and history of preceding diarrheal illness, recent CMV, hyponatremia, and whether the immunomodulatory has been initiated early. Early initiation of immunomodulatory, better response. So, this was rather an easy question, actually, which is something which we have discussed. Severity of weakness is the most important factor, which one of the most important factors to predict the outcome at 6 months. Then again, the second question, I don't know what is exact options given, but C7 supply was asked. This also I had been discussing during the preparatory session also. They can ask the dermatomal value. Previously, they asked the axle is supplied to which dermatome. Similarly, C7 supplies is actually an easy question which we have discussed. C7 supplies is the middle finger, and this area is supplied by the C7. So it was an easy question. So that was actually a rather very simple question. I has been discussing when we were discussing about the session as well as doing the preparatory part. I have been telling that they may ask about radical because it's one of the favorite area. Previously T2 has been asked, and now they asked about the C7. It supplies triceps and the centermost portion, distal and dorsal arm, third digit. This is something which we have discussed. So coming to next, again it is another radical has been asked. Disease involving S1 root space. I have told you that there is some mnemonic like thing I have told that hip flexion is L1 and hip adduction is L2, knee extension is L3, L4 is plantar dorsiflexion, then plantar flexion, knee flexion, hip extension, all these are by S1. So you know that knee extensors are L3, that is enough to answer it. So it was rather very simple question. This is also same from our discussion. So all the three questions till now are simple questions, not difficult ones. So coming to the next question, this is one question I liked it very much. So if you go through the question first, the patient developed pain over the one lower limb from hip till ankle. So there is a sensory symptom from hip till ankle. Then patient developed weakness of same limb associated with weight loss of 13 kg. And which of the following mechanism is underlying pathology? So when you see this question, if you come out after having the tough questions of muscle and NMJ, if you come and directly see it, you will think that this exam is not mine. I am going to leave this. I am not going to answer it. This is not for me. But if you again go to the option, you will get again dense because you have some big terms, mitochondrial dysfunctions, ventricular deposition, microvasculitis. Even when the first time when I saw this question, I thought, okay, this may be something very tough. But then I calm my mind and then just go through the question. This is a clinical question basically. So any clinical question, try to arrive at a clinical diagnosis, then proceed. That will help you. So come and go through this question. Patient developed a pain over the one lower limb from hip to ankle. That means a sensory symptom involving single lower limb. So you have a sensory symptom involving single leg. Okay. Then followed by motor, and that is hip till leg. So it's a sensory motor syndrome. So it cannot be an anterior horn cell. Okay. Unilateral weakness, it should be, I had been explaining during the discussion also that when you have a unilateral weakness, the diagnoses are very less in lower limb. Sensory motor syndrome, it can be either a cauda or a plexus. Mononeurate is very less likely because hip till leg means you have multiple radical, multiple nerve, multiple mononeurate is localized into single leg. It's very unlikely. So you have either a cauda or a plexus. So you come to cauda will have bladder involvement, and sensory is more significant than weakness, and it may have back pain. Nothing is there. So and again the weight loss, that is again something which is against cauda classically. So this weight loss can occur in lot of neurological disorders where you have neuroinflammation, like degenerative disorders also, Parkinsonism, ALS, even MSA, atypical Parkinsonism, they all can have weight loss. So here is something which is a sensory motor syndrome which is involving single leg with wasting. So it should be a plexus most likely without back pain. So and again you go to the plexus, we have discussed about plexitis, you can have what a type of plexus involvement you can have either because of trauma, okay, or because of a tumor, either invasion or compression. Third is a diabetic plexopathy, and fourth one is idiopathic where you don't have the exact cause. Fifth one is a radiation plexitis. So trauma, it is because of direct trauma of the nerve. Tumor, it is because of either invasion or a compression. Then a diabetic plexus where it is because of inflammation and microvasculitis. What is microvasculitis? You know the diabetic neuropathy where you have the vasovascular which is supplying the nerves. There is microvasculitis, or there is small vessels are damaged and ischemia of the nerve is happening. That is the reason for diabetic neuropathy. Same mechanism here. There is microvasculitis. Then idiopathic, also inflammation, microvasculitis. Radiation, where you have significant inflammation and fibrosis of the plexus. So here it is patient history is not given. It is started with pain followed by weakness. That is typical for idiopathic plexitis. We had been discussing this even in the brachial plexitis, like Parsonage-Turner syndrome, where you have initially severe pain. The patient comes to you with pain of the hand. Examination, there is no weakness. You will label it as myofasciitis or myofascial pain syndrome or muscular pain. Later, after 2-3 weeks, they comes with wasting and weakness. That is classical for idiopathic plexitis. So, the mechanism here is microvasculitis plus inflammation. So, the best answer is microvasculitis. If you go it in a systematic way, any clinical question, you go and analyze and find out the answer, find a clinical answer, then you go into the option, then it will be easier. If it is tougher question. Okay, so peripheral nerve, I felt all the 4 questions were not tough, they were all answerable, even though if you keep the lumbosacral plexus, that is bit difficult, but it is answerable if you use some common sense. So, till now we have the muscle and NMJ, the tougher part, the peripheral nerve is not tougher. So, then coming to the demyelination, the first question is which among the following drug causes flushing as a side effect. This is something which we have discussed about this table, but in the table if you see, there is a lot of the side effects which are important, you remember. But this is something which seemingly unimportant, but DMF, dimethylfumarate fumarate causes flushing. So, the answer is DMF, dimethylfumarate fumarate causes flushing. We have discussed about side effect and we discussed the effect, everything about all these newer drugs we have discussed in detail in the MS session. If you have any doubt, you can go and watch that session. Then coming to the next question, this also looks tougher, but it is very easy. Among the options, it made it little bit tougher. A young female with, I don't know exactly what are the options given and what was the exact question. This is something which I got from the root of the question. Young female with optic neuritis, which among the following factors indicate the least risk of progression to multiple sclerosis? So, when we were discussing about the optic nerve in optic neuritis, I told you, well, the investigation of optic neuritis, you go there, when we discussed in the MRI, I told you that whether there is a need of taking MRI in optic neuritis, especially brain. That is very significant because if you have an MRI features suggestive of MS, even though there is no clinical findings of multiple sclerosis in the patient other than optic neuritis, single optic neuritis, the likelihood of progression is 75%. So, the most important is MRI among the given variables. Risk of progression, residual degree of visual loss doesn't tell you risk of progression. Residual degree of visual loss means that the damage is severe, it may be something in MMO or something else, but the risk of progression to multiple sclerosis will tell not by the residual damage, because when you present as optic neuritis, many times it improve very good, very spontaneous improvement, not spontaneous, with the steroids very good improvement will be seen, but that doesn't predict the likelihood of progression. Likelihood of progression is predicted by the most important variable is MRI showing MS-like lesion. So, the most important thing is MRI in this option in this question. The presence of brain abnormality at the time of optic neuritis attacks is a strong predictor of 15-year risk of MS, which we have discussed in our module. We told that around 75-fold risk is there if MRI is suggestive of MS. Some features of MS is there in MRI. If even with isolated optic neuritis, risk of progression is very, very, very high. Okay. So, that is why that question answer is normal MRI. Then coming to the next question. This is again a tricky question. I didn't get the exact wordings here in the question, but this is the root of the question. A 30-year-old female presented with some history of headache was there, history of bilateral hearing loss in 6 months, stepwise vision loss since 2 weeks, bilateral cerebellar lesion, multiple cranial nerve palsy. What is the diagnosis? When you go to the question, headache, bilateral hearing loss, okay, and visual loss, stepwise visual loss, you think headache, visual loss, hearing loss, your answer spontaneously will come as Sussac syndrome. Sussac syndrome. So, we'll go into that. Sneddon syndrome is again autoimmune, where you have your livedo reticularis, like skin is a classical feature, livedo racemosa. So, that is not the answer, which is a thrombotic vasculitis. It is not the answer. It doesn't present with headache, bilateral hearing loss, not the presentation. And again, livedo reticularis is not there. And then comes to Sussac syndrome. Sussac syndrome can have headache, yes, definitely. History of bilateral hearing loss, yes, definitely, because of there is retinal and cochlear vasculitis, endarteritis, and you can have even a visual loss can be there. But the odd point, there are 2 odd points in this. First of all, multiple cranial palsy doesn't fit to your Sussac syndrome. Cerebellar lesions are not a feature of Sussac syndrome. Sussac syndrome, it is corpus callosal lesion. I have discussed about it. In the center of corpus callosum, yes, central fibers are more affected, snowball-like opacities associated with corpus callosal lesion, headache, visual loss because of branch retinal artery occlusions, and hearing loss. These are 4 features of Sussac syndrome. Sussac syndrome is not the answer. Then aggressive MS, I have told many times the red flag signs. Headache is not a feature of headache, encephalopathy, hearing loss, nothing, none of these can present in MS. Multiple element cranial palsy, never in MS. So, the answer is a primary CNS vasculitis or primary CNS angiitis. They can have meningeal involvement, they can have multiple cranial palsy, all these findings which has progressed over 6 or 7 months, that is a classical, can present in a primary CNS angiitis. Headache can be there. Headache is the most common presentation. One of the common presentation. Then bilateral hearing loss and multiple cranial palsies and cerebellar lesion. All those things can present in primary CNS angiitis. So I think the best answer is primary CNS angiitis. So demyelination, all the 3 questions were easy. So peripheral nerve and demyelination saved your question paper till now, but the first 6 questions were tough. But that you discussed around 13 questions, only 6 were tough. Then coming to movement disorder, there are 7 questions. First question again, all the exam paper, there is 1 question from atypical Parkinsonism. There will be either a SINU about the proteinopathy or the clinical presentation will be given. Most questions are from PSP only. Here again, elderly patient with recurrent falls, symmetrical rigidity, gaze abnormality, which the following pathology fits for the above disease. Okay. Again, it is very clear from the history, there is recurrent falls in elderly patient. And there is symmetric like Kennet-Rigid syndrome with recurrent falls, early falls, the classical feature of PSP. Again, gaze is classically for PSP, progress is supranuclear palsy. Again, you know that it is a synucleopathy. We have discussed about it multiple times of proteinopathies. Every time one question is coming from proteinopathy. So the answer is synucleopathy. I am not going to discuss it in detail because synucleopathy, tauopathy, all those things we have discussed many times in our modules. Okay. So coming to the next question, the 15th question. Characteristical Parkinsonian tremor. This also we have discussed. The postural tremor is classical for your essential tremors. Orthostatic tremor is not a classical, not at all seen in Parkinson's and classical. It is a rest tremor is something which you see in Parkinson. We have discussed that when you have a rest tremor and which improves on movement, that means there is dopamine insufficiency is there. Dystonic tremor can occur in Parkinsonian syndromes, but re-emergent tremor, which we have told, that is a very significant and very typical for Parkinson's. Okay, so the emergent tremor is the answer, which when you keep the hand like this, initially there is no tremor. Few seconds later, you will see the tremor coming back. That is a classical feature of Parkinsonian tremor. That is re-emergent tremor. That is not the classical postural tremor. In a essential tremor, when you keep it, only the tremor will start appearing is essential tremor. When you keep it like this, there is no tremor. Slowly after some time, the tremor keep on appearing. That is known as re-emergent tremor of Parkinson's. So coming to next question, the patient Parkinson's has wearing of effect and levodopa induced dyskinesia. Which of the following DBS should be done to reduce the coriform dyskinesias? Again, even though the question looks very much difficult, the options is not at all difficult. The option is very easy. The option is STN, thalamus, substantia nigra and putamen. See, the first of the basic thing, GPA and STN are 2 sites of DBS which has been approved. No other site has been FDA approved for Parkinson's until now. So there is no GPA in the option, there is no confusion, the answer is STN. If you go like that simply, even without reading the question, you just read the DBS and go into the option, you will get the answer. DBS in Parkinson's, STN and GPA. This is something which we have discussed in our module, the same slide from the module. Here you see, there is a drug-induced dyskinesia with motor fluctuations, severe motor fluctuations, no improvement, STN or GPA DBS. We have discussed about DBS, what are the pros and cons, everything we have discussed in the module. GPA DBS is useful for troublesome dyskinesias and mild or cognitive behavioral disorders. The major cognitive impairment, you cannot go with STN GBS, subthalamic nucleus GBS may worsen it. So you have to go with GPA GBS. Okay. So if a cognitively intact, you can go with STN. Cognitively severely affected, don't go with STN, go with GPA. All these things are again difficult. Otherwise, STN is a best site. Again, in the option, it is no need to know any of this. You knew that STN and GPA are 2 sites. There is no GPA in the option as much as I got the answer from all the students. Whatever I got, GPA and GPA was not there in the option. The answer is STN. Okay. Then coming to the next question. Question number 17. A 60-year-old female with non-case of hypothyroidism with history of dementia, and it was given either something like unilateral rigidity or something, exactly not sure, one side weakness or rigidity and hyperreflexia. That means the patient has dementia, cognition, then he has a weakness bar rigidity and hyperreflexia. That means pyramidal plus or minus extrapyramidal involvement. Myoclonus, that means a cortical or extrapyramidal involvement. Okay, you have to assess it. Whenever you have a clinical case, you assess it. Go like that. For the last 6 weeks, CSF is normal. What is the next step? So the image is given below. What is the next step? So here the catch point is rapidly progressive dementia and CSF being normal with cognitive impairment, pyramidal and extrapyramidal. you will think of rapidly progressive dementia. First thing comes to your mind is CJD, and the image also shows a cortical ribbon-like pattern. The confusion arises with NMDA. NMDA doesn't present like this. NMDA present classically prodrome phase is there, and you will have not the MRI findings are not like this. MRI findings is NMDA usually can have a focal encephalitis, doesn't have this cortical ribbon pattern classically. And NMDA present in younger, usually classical in younger females. They present with initially with a fever-like episode followed by psychiatric manifestation. Then they will go for some rigidity. Then they will go for next phase of your autonomic failure and all those things which we have discussed in our module on MCQ module about autoimmune encephalitis. This is not the answer. So, the best answer is 1433. If RT quacking was there, that might have been a best option when compared to CSF 1433. RT quacking is the best test, best available, more specific test for this thing rather than 1433. So, the option it was not there. So, the answer is 1433. The diagnosis is again CJD. So, it is actually rapidly progressive dementia. First thing comes to your mind is CJD. There are some certain things they had put, hypothyroidism, then a female, all those things are make you to confuse more. A 6-year-old female with dementia rapidly progressing with extrapyramidal and pyramidal with myoclonus, there is no other diagnosis, it is CJD. If you have the MRI, first thing we roll out is CJD. So, these things we have discussed in the modules, the pattern of involvement and all those things we have discussed in the module. I am not going to discuss about that. You actually do not need those things to answer this question. Essential tremor, which is wrong. Essential tremor can have a large handwriting, while Parkinson's can have a small handwriting. So, that is true. Okay. It is a high frequency tremor. The highest frequency is for orthostatic tremor, which we have discussed in the module of tremor, but still the frequency is between higher side. Lowest frequency is for myarrhythmia. So, that is also relatively true answer. It is an autosomal dominant, not a recessive. That is a wrong statement. And bilateral symmetrical tremor is classically seen in essential tremor. So, it is also a very easy question. So, this was frequencies of different tremors which we have discussed in our module. So, the answer for this question, essential tremor, the wrong statement is it is not autosomal recessive. Then coming to the next question, this is actually I do not know exactly whether it is a neurology or from hepatology. Anyway, this is regarding Wilson disease. Wilson disease, the total copper is 28 micrograms, ceruloplasmin is 4 milligram per deciliter. How much is a free copper? This there is some equation is there. This actually which I found out again. This is for me it is a tougher question because we don't practically don't use all those things. So, free copper is equal to total copper in microgram per deciliter minus ceruloplasmin into 3. So, here the total copper is 28 minus 3 into ceruloplasmin, that is 4. That is 28 minus 12, that is 26. That comes to your mathematics. The mathematical question, the answer was 26. For that you need to know this question maybe, I mean this formula maybe. And the next question is a young patient with a history of Parkinsonism on drugs develops gambling behavior, addiction to pornography, and the likely agent is this. We directly have discussed in our module. Dopamine agonist, when you start, you can have the activation of the mesolimbic, mesocortical system, all those things, the reward pathway, all those things we have discussed. So, the answer is a dopamine agonist, that is pramipixole, classically seen in pramipixole, rarely seen associated other dopamine agonists also, dopamine also you can see, but classically seen in dopamine agonists. So, we have discussed all those things in our module. Pedal is a main concern, excessive daytime sleepiness can be there, dopamine dysregulation syndrome can be there, impulse control behavior and funding, the serial arrangement of things, all those things we have discussed in the modules. So, this is a classical side effect where you have a dopamine dysregulation or when you have, you cannot control your reward pathway properly, that will result in this gambling behavior, addiction to pornography, all those behavioral issues are classically seen in dopamine agonist, that is pramipixole. Clear? The answer is pramipixole. This is something which we have discussed in our module. So, in the movement disorder, we have discussed 7 questions. I felt one question is difficult. That one question is actually your Wilson's, which I felt it is difficult, which is new for me. Frankly speaking, it is new for me. And I felt muscle 3 out of 4 was tough. NMJ, all the both are tough. These 2 were easy. So, till now, our score is for almost 6 questions are tougher. Now, coming to dementia and cognition. This is rather very simple question. NBH triad includes all except, which we have discussed. NBH classically have gait, urinary and dementia is a classical feature. Altered sensorium is not a classical feature of NBH. This happens when you have a delirium overlying to an NBH. Otherwise, altered sensorium is not a feature of NBH. Dementia, gait and urinary incontinence. Okay, that is very easy. So coming to the next question, this is not any, it's a new question which we have not discussed. Actually interesting questions also. Patient with sympathetic apraxia, lesion in which area? Option A is corpus callosum, option B is supplementary motor cortex area, and other areas, I mean other options I am not sure. I am not sure whether it is given that left or right, that also I am not sure. So what is sympathetic apraxia? That is inability of a non-pathogenic hand to carry out commanded movements. Suppose I have a left-sided motor cortex involvement, I will have weakness of my right hand, clear? But here, if the left-sided motor cortex, I have a left-right hand weakness, along with that, or I have a left side weakness. See, I have a left motor cortex stroke, I have a left hand weakness. That is something known as sympathetic apraxia. So, you know that your praxis, your origin of praxis, that means how to do motor activity happens on the left side, praxis. This is the left side, this is the right side. Right side controls left upper limb, and left side controls right upper limb. Clear? This much is clear. So this is what is happening. Your movement formulas and everything happens in the parietal lobe. That goes to the motor programs in the left SMA. Left SMA crosses where the corpus callosum to reach the right SMA, and ultimately this controls the left hand or left limb output. But this controls the right limb output. Suppose I have a stroke which happened on my left SMA. So what happened? Because left SMA is damaged, my right hand cannot be controlled because left side controls right upper limb. So I have a right upper limb weakness. That is a normal phenomenon. When you have a left motor cortex damage, right upper limb weakness, that is something which is normally happening. Because the motor programs from here cannot cross the corpus callosum. My right side brain is not receiving any motor programs. My right side brain is not receiving motor programs from the left praxis programs are not reaching there. So what happens? My left upper limb also cannot act because apraxia happened here. Okay. So this is known as sympathetic apraxia. Here my left motor cortex is damaged. My left hand cannot move or cannot do an activity like a weakness because of apraxia. Same side. That is not known to happen. My left side is damaged, I was supposed to have a right side weakness. Along with the right side weakness, now I have a left sympathetic apraxia because of left hand abnormality, because my motor programs on the left hemisphere cannot cross the right side, so it cannot come down the pyramidal tract to my left side. So if I have a left SMA damage, I may be able to do some activity of right side because my primary motor cortex is intact. I may be able to do some activities, but apraxia is still there. But left side, same side, I will have an apraxia of hand. That is known as sympathetic apraxia. Clear? So sympathetic apraxia means, suppose my left SMA is damaged, I will have a right hand weakness because of your crossed innervation. But I will have a left sided again a weakness, which is not a weakness, it is an apraxia. I am unable to do activities left hand because the motor movements originating from the left side cannot cross to the right cortex to control the left side. So that is known as sympathetic apraxia. So the answer is supplementary motor cortex. This also is a difficult question for me. So sympathetic apraxia means you are having a damage on one side. That means your left side cortex is damaged. You are supposed to get pathological weakness on the right hand. But here, even on the left side damage, you are getting left hand, the same side, non-pathological hand weakness because of apraxia. That is known as sympathetic apraxia. Clear? The answer is supplementary motor cortex, because the supplementary motor cortex is gone on left side, it cannot cross to the right side and give a command to the right cortex to control the left limb. Clear? Looks a bit tougher, it is a very core neuroscience question. So left parietal lobe lesion, this I am not going to discuss. So memory loss in Wernicke's encephalopathy, this is again a repeat question. Wernicke's encephalopathy circuit, every time it is asking. And Wernicke's encephalopathy, I discussed about a Pappas circuit in memory, where I have discussed about a Pappas circuit, where the memory comes from the hippocampus, it goes to the fornix, goes to the mammillary body, then anterior nucleus of thalamus, then goes to the cingulate gyrus, goes anteriorly. So it should be the. So the next question is memory loss in Wernicke's encephalopathy is due to. This is actually Wernicke's encephalopathy circuit. Every time they are asking the question. So Wernicke's encephalopathy, we have discussed about Pappas limbic circuit. This is a pappus limbic circuit where your medial hippocampus to the fornix, then to the mammillary body, then the thalamic nuclei, and then to the frontal lobe. This is a pappus limbic circuit. So, classically, the damage happens in the mammillary body with the necrosis of the hemorrhagic necrosis of mammillary body. It's a classical mechanism which happens in the Wernicke's. This circuit is predominantly affected in Wernicke's encephalopathy. So, among the options, I think the anterior nucleus of thalamus is the best option available in the option. I am not sure about other options. This is something which I got from the students. So, I think among this, amygdala has nothing to do with the pappus limbic circuit. It is a part of memory where the fear associated memory is there. Medial temporal lobe, yeah, medial temporal lobe is a big structure. In that hippocampus is involved in the circuit, but anterior nucleus of thalamus is a better option. So, that was about that question. Next question again from the working memory, that working memory is a function of, this is actually simple question where you know that working memory is a function of attention, which we have discussed working memory, about the types of working memory. You need a visual spatial sketchpad, episodic buffer, phonological loop, everything has been discussed in our module. So, next question is regarding the aphasia, conduction aphasia, which among the following is false. So, we have discussed about aphasia multiple times, like you have central sulcus, you have anything happening here will affect your repetition, anything happen here will affect the fluency, posterior to central sulcus affect the comprehension, okay, fluency. This we have discussed in our module. So, the conduction aphasia is something which affect in this area is a conduction aphasia where repetition is totally gone, but fluency is relatively intact, but you will have some errors in the spontaneous speech, and comprehension is unaffected. The fluency and comprehension is unaffected and not completely unaffected. You see it is fluent. This is a bedside test for conduction aphasia, is fluent, hesitancy is there, literal paraphasic errors are there, but you see the comprehension is intact. Here the wrong statement or the false statement is comprehension is affected is wrong, where the comprehension is unaffected because it is relatively around the repetition arc is affected. So, repetition is dominantly affected, fluency is preserved, but some hesitancy will be there, comprehension will be intact. So, that is a classical conduction aphasia. So, the wrong statement is comprehension is affected. This also I felt is not a difficult question. If you know the circuitry properly, it is not a difficult question. So, altogether from the cognition dementia, 5 questions I felt except the sympathetic apraxia, that is 1, remaining 4 were relatively simple. Movement disorder we scored 1 was tough. So, again the number of difficult questions are less. Then come to cerebellum, only 1 question came. I was expecting more questions, but only 1 question came, and that was actually in fact a simple question that which we have discussed in the module. The climbing fiber received efferent from. Though there are 3 layers in cerebellum which we have discussed: the granular layer, the Purkinje layer, and the molecular layer. Granular layer contains the granular cells and the Golgi cells. The molecular layer contains the stellate cells and the basket cells. The Purkinje layer contains the Purkinje cells. The Purkinje layer or the Purkinje cell is the major output. Okay. So, the input comes from the granular and molecular layer. The granular layer is only stimulatory cell. The granular cell, this is only stimulatory cell. Okay, that is a major input. So, climbing fibers gets input from the inferior olivatory nucleus, while all other fibers give the input to the cerebellar nucleus through the Mosey fibers. There are 2 fibers, Mosey fiber and climbing fiber. Everything goes to the Mosey fiber except the input to the input from the inferior olivatory nucleus, which goes to the climbing fibers, which we have discussed in the module. So, the inferior olivatory nucleus is where the climbing fiber has role. Remaining all input to the cerebellum goes through Mosey fibers. So, there are 2 fibers, Mosey fiber and climbing fibers. Mosey fibers all input except those from the inferior olivatory nucleus. So, this was a question. So, cerebellum, that question is not tough. Epilepsy, the maximum question, 8 questions, many are actually simple. The first question was from epilepsy was, the patient with one unprovoked seizure, to diagnose epilepsy, the patient, what is needed? This is something which is directly from the new definition, not a new definition, 2017 definition, and which we have discussed on module. 60% risk of recurrence of seizure in 10 years. Either it can be 2 unprovoked seizure or a single unprovoked seizure with epileptic brain lesion or epileptic abnormality in the EEG. Okay, so clear. So, 60% risk in the next 10 years is the answer. The abnormal brain imaging doesn't tell us anything about epileptiform or non-epileptiform. So, that is not the answer. Neurological deficit has nothing to do. Either a single episode with 60% risk, which is proven by either an epileptiform abnormality in the EEG or an epileptiform MRI abnormality. Okay, so that is one unprovoked seizure means that is 60% risk of the next 10 years is by one more epileptiform abnormality in the MRI or an epileptiform abnormality in the EEG, or it fits to an electroclinical syndrome of epileptic encephalopathy or something like that. So the answer is 60% risk over the next 10 years. Epilepsy with best prognosis. All these are epileptic encephalopathies. Actually, we have not discussed much about early myoclonic and infantile epilepsy with migrating focal seizure and all. But when we are discussing about in the module, I told that LKS or Landau-Kleffner syndrome is something which has a better prognosis, because by 15 years they will grow out of the epilepsy and slowly the cognition, everything slowly improve, but not comes back to the normal, but they will improve. LGS is very bad type of epileptic encephalopathy where they have mental retardation, severe mental retardation, severe seizures, all those things. So Lennox-Gastaut is not the answer. Early myoclonic encephalopathy, the migrating focal epilepsy of infancy is something which we have not discussed. It is actually a focal seizure with autonomic manifestation. Death occurs within 1 year. This is a dreadful, very severe epilepsy. So the answer is LKS, where you have improves with 5 years, 50% related normal life, 20% complete normal life. Early myoclonic encephalopathy is one of the most dreadful disease. Again, this is something which you have discussed in the module. So Landau-Kleffner syndrome, whereas epileptic aphasia is there, where you have increased seizures during the sleep. LKS and CSWs, both goes together. All those things we have discussed in the module. If you go to the module of epileptic encephalopathy 1 and 2, you will be able to answer this question. So this is also not a tough question. Then coming to the next question, the complex visual and auditory hallucination involved in which area? So also we have discussed the semiology of seizure. You have the brain liking like this is occipital area, the frontal, this is a parietal, and this is a temporal area. So you have the primary occipital area. When this seizure is in the primary occipital area, what happens is the primary occipital area is relatively concerned about the brightness, color, all those things. You may see bright star-like image or something bright colored images which increase in size. All those things comes when it affecting the primary occipital area. The processing happens in the secondary occipital area. When you are seeing a visual scene, like some humans are there, some animals coming and attacking, that is a complex visual hallucination, not a simple hallucination. When you see a bright light, that is a simple hallucination. When you see a complex thing, there is like a visual imaginary, a scene is seeing, an image is seeing, a sounds are there, just sound like beep sound, that is a simple hallucination. When you see a particular voice of a person, that is a complex hallucination. When complex thing happen, that requires your multimodal areas, that also we have explained. That means it requires your association areas which comes in this area, that is the occipito-parieto-temporal area. So that requires, it is not in the parietal, it is not in the medial temporal, it is not in the central cortical, it requires your lateral temporal. Actually not the exact lateral temporal, it is a lateral temporal and lateral occipital area which is involved in the visual association area, which also we have discussed in our module in epilepsy of semiology of seizure. It is very simple actually if you go on to that module. So which of the following disease requires indirect EEG is needed for diagnosis? This is rather interesting question. When I was taking about EEG as well as epilepsy, I repeatedly was telling EEG is never used for gold standard for diagnosing epilepsy. You can use epilepsy to diagnose certain epileptic syndromes and you can give a clue for diagnosis, but even if EEG is negative, that doesn't prove that the patient doesn't have epilepsy. Okay, so epilepsy is never required for the diagnosis, for diagnosing an epilepsy, for diagnosing epileptic syndrome. It doesn't need an EEG for diagnosing it. You can diagnose with history and MRI. Suppose a patient comes to you with a focal epileptic syndrome like complex visual and auditory hallucination, and MRI is taken, epileptic lesion is there on the lateral, you can diagnose it as epileptic encephalopathy. It doesn't need, epileptic doesn't need an EEG. But you see PNE, psychogenic non-epileptiform attacks, where you need to prove according to DSM-5, DSM definition, you need to prove it by provoking it in EEG. If EEG is a gold standard for diagnosis. Medial temporal epilepsy you can diagnose even without EEG. If suppose a patient comes to you with automatism followed by seizure and EEG is perfectly normal. Majority of the time medial temporal epilepsy EEG will be normal because normal scalp EEG won't pick up the hippocampal area or the medial temporal area. So that will be normal. But you diagnose based on the history, plus or minus your MRI. So that doesn't require EEG. Rolandic epilepsy is a clinico-epileptic EEG syndrome that you require an EEG finding, but it is not always something which is diagnosed with EEG. But PNES, according to definition, you require a gold standard for diagnosis of PNES is by EEG showing. I think the best option is PNES. Again, there is a confusion between C and A for me, but I feel the best option among the options is PNES, because as per definition, the gold standard for diagnosis of PNES is an EEG showing an activity without electrical correlate. Patient is showing seizure-like activity, but the EEG doesn't show seizure. That is enough to diagnose that as PNES. So that is one of the among the question. I feel this is a little bit tougher one. Among the following, which is not a sodium channel blocker, is a very easy question. We have discussed levetiracetam, which act on synaptic vesicle transport. So answer is levetiracetam, phenytoin, sodium valproate, carbamazepine. All these are sodium channel blockers. Okay, so the answer is very easy. We have discussed it. Levetiracetam. Anti-seizure drug associated arrhythmia. This also we have discussed. Levetiracetam doesn't cause arrhythmia. Valproate in toxic dose sometimes can cause arrhythmia, but usually not. Lacosamide we discussed, they can cause abnormality in the PR prolongation, PR abnormalities, PR segment abnormality can occur in lacosamide. Lacosamide is known to produce arrhythmia. So this is also something which we have discussed. If you use little bit logic, you will be able to answer this. Patient with epilepsy, low IQ, skin lesion suggestive of, again it's very direct question. It's classical tuberous sclerosis triad, epilepsy, low IQ and skin lesions, adenoma sebaceum or the other skin lesions, ganglion patches, ash leaf modules, all those things are there. And I think this one more question was there, what is the probable diagnosis? What you are seeing is some cortical hyperintensities, is MRI, and you can see some periventricular nodular lesion. This is classical of tuberous sclerosis. These are the cortical tubers and subarachnoid nodules of tuberous sclerosis. So, tuberous sclerosis MRI will have subarachnoid nodules which shows calcification in CT. The subependymal nodules of tuberous sclerosis, they have skin abnormalities, Chagrine patches, all those things. Then mental retardation, seizures, and this is SEGA or subependymal giant astrocytomas. These are also we have discussed in our module in neurocutaneous syndrome. These are large giant astrocytomas. They can cause obstructive hydrocephalus. You can see hydrocephalus developed here. And these are the cortical tubers which are hyperintense on MRI in the cortical areas. So, cortical tubers and ependymal nodules are common, SEGAs are not that common thing. So, the answer is tuberous sclerosis. Okay. So, in the epilepsy there are 8 questions asked. I included this neurocutaneous syndrome into epilepsy, but I felt little bit tougher question was PNES related question. I feel that maybe little bit confusion might be there. Other questions are not that tough. Then coming to the headache, only one question which is very simple. A female with moderate headache for weeks and BMI is 34, that means he is obese with bilateral papilledema. So, headache with bilateral papilledema in obese female, direct diagnosis there, and which among the MRI finding, that is diagnosis is most likely diagnosis. The first thing is IAH, idiopathic intracranial hypertension, where a female obese fatty female with papilledema and headache. MD cell is a classical finding. Typical imaging findings, one is slit like ventricles, empty cella because of pressure, pituitary will be not seen, that is empty cella, and posterior scleral flattening and diffuse transverse sinus venous stenosis. Even if you are not remembering about these two, this is a common two findings which you must know even in your MD days. Empty cella with headache in a female with papilledema, the first diagnosis is IAH. Oh, this is something you can see, there is optic the fundus edema. You can see here, if you see here clearly, you can see the optic nerve edema, that is a papilledema which can be sometimes seen in MRI. Here you can see the sclera, the posterior part of sclera is little flattened. Look at here, the sclera is circular. Here it is little bit flattened. So, flattening of posterior scleral flattening, again another sign of IAH. You can see the enlarged preoptic space around the optic nerve, that is also another finding. And this is a classical empty cella where the cella is the anterior pituitary normally seen. Here the CSF, here this is abnormal in IAH, this is a normal. In IAH what is happening is the CSF space increases and the CSF space will enter inside the space and compress, and that is gives appearance like cella is empty, that is empty cella. So, among all the radiological signs of IAH, you should know only the major things, at least the major things, that is slit like ventricles, and empty cella. That will be enough for your level. I just put the other figures also, don't get confused. So that question was actually in fact not that difficult one, because the clinical diagnosis itself was putting forward you that this is an IAH. Okay. So from headache only one question, that is very simple question for me. I felt it is very easy question. Even though the radiological finding was asked, the options was empty cella. It was not other rare findings of IAH. Then coming to stroke, in fact 5 questions came from stroke, but unlike the usually when you get the questions from the stroke, you will have some questions about intracranial bleed. Then you will have some questions about aneurysms. You usually used to get questions regarding the management of stroke. Here the most questions are a little bit different, like vascular anatomy, basic stuff, little bit tough. The first question was superior cerebral artery does not supply. We were studying about MCA, PCA, SCA, all those things. Why the superior cerebral artery came from? So this is something which we have discussed. You have your brainstem. So we have discussed in our module like the superior cerebral artery supplies us the upper part of cerebellum and some area of the pons, the lateral area. We have discussed that you have the pons. I mean, this is a medulla. This is a pons coming like this. Then you have the midbrain, and your vertebral artery comes and joins together and form the basilar artery. Then basilar artery divides into PCA, and here you have the posterior inferior cerebellar artery. This is the anterior inferior cerebellar artery. Here is a superior cerebellar artery. So superior cerebral artery, predominant anterior inferior cerebellar artery supplies the lower pons. These all things we have discussed. So in the discussion we have discussed that the superior cerebral artery basically supplies some of the lateral areas of pons, and predominantly it supplies the cerebellum. Clear? So the medulla has two areas supply. The paramedian medulla is supplied by the paramedian medulla is supplied by the vertebral artery and the anterior spinal artery. The lateral medulla is supplied by vertebral artery and posterior inferior cerebellar artery. Because posterior inferior cerebellar artery comes to the lateral area, the vertebral artery comes to the lateral area, and it joins to form the basilar artery. Two vertebral artery joins to form the basilar artery at the pondo-medullary junction. Okay, so pons, the lower lateral part of the pons, is supplied by anterior inferior cerebellar artery and some of the basilar artery branches. Okay, and the upper pons and the paramedian pons is supplied to the basilar artery branch. Clear? So lower lateral pons is supplied by anterior inferior cerebellar artery. The paramedian pons and the some of the lateral areas is supplied by the basilar branches. So the superior cerebellar artery basically supplies the cerebellum, the upper area of the cerebellum, and some lateral area of the pons and midbrain. Okay. So the options contains oculomotor nucleus. Then it contains superior cerebral peduncle, medial lemniscus, spinothalamic tract. So the oculomotor nucleus is something which lies in the midbrain. Remember, the midbrain has third nerve nucleus is located in the midbrain. You see the oculomotor nucleus is coming in the midbrain. So midbrain has no supply, predominantly the superior cerebral artery has nothing much supply to the midbrain. And one more thing is the oculomotor nucleus is located in the middle part of the midbrain. The superior cerebral artery, even if it supplies some of the lateralmost area of the pons and some lateral areas. So the oculomotor nucleus just comes in the midbrain, and the center of the midbrain, which is not supplied by the superior cerebral artery. There is no need to going into other options to confuse. And the medial lemniscus and spinothalamic tract is located slightly lateral, and even medial lemniscus is middle, but this oculomotor nucleus has no relation to the superior cerebral artery because it is a midline. If you see here, the medial lemniscus in the upper pons and towards the midbrain, it is located more or less slightly lateral. So that can have some supply of superior cerebral artery, but the oculomotor nucleus, which is located in the middle of the midbrain, doesn't receive superior cerebral artery supply. So that is what I think the best option is oculomotor nuclei in that question. Then coming to the next question, a patient presented with headache and dilated pupil followed by complete third nerve paralysis. So headache followed by pupillar affection. This we have discussed, this classical presentation of PCOM. See, this also we have discussed. This is the third nerve and This is a PCA. This is a superior cerebral artery, and this is a PCOM. So PCOM lies just next to the third nerve. So PCOM aneurysm will compress the third nerve. So pupillary fibers are in the outside of the third nerve you take. The pupillary fibers are located in the outermost area comes the pupillary fibers. So when the compression happens, the outermost structures are first compressed. So pupil is first affected, headache followed by pupil, followed by third nerve, classically seen in PCOM rupture. ACOM is located very anteriorly, no relation to third nerve. ACA is again located anteriorly, no relation to third nerve. So the answer is PCOM rupture. Okay, that is actually in fact very easy. This may confuse you, but it is very easy. A patient with mitral valve prolapse with recurrent TAA following is a treatment. So you think there is a mitral valve prolapse, you go for anticoagulation? Never. I have specifically many times I point out that when you are treating a cardioembolic stroke, it should be valvular. When you consider as a valvular AF, you will think of either a severe mitral valve stenosis, moderate to severe mitral valve stenosis, or replaced valve. AR, AS, MR, all those things are not considered as a cardiogenic AF or a valvular AF, not cardiogenic, valvular AF. Okay, clear. So mitral valve prolapse is not considered as fitting to criteria for valvular AF. So it should be treated like any other TAA. Any TAA, your treatment is aspirin and clopidogrel. It is not a single antiplatelet, dual antiplatelet for TAA and minor stroke according to the guideline which we have discussed in a treatment of stroke. So dual antiplatelets for minimum period of 3 weeks based on certain studies. Okay. So that is a treatment is aspirin and clopidogrel, not anticoagulation. Why not? Because mitral prolapse is not considered as a valvular AF, cause for valvular AF. It is moderate to severe MS or a valve replaced. Then you will consider as a cardioembolic source. Otherwise, you won't think of a cardioembolic source unless there is a LV apical clot. So those with mitral prolapse with recurrent DAA, you have no guidelines to give anticoagulation. Clear? It should be considered as any other normal stroke. Patients with ulcerative colitis develop moderate headache for 6 weeks. Diagnosis. This is actually a bit tricky. Even I have to refer it. IBS, CNS manifestation, cerebrovascular demyelination and other causes also there. Threefold risk of CVT compared to general population. So it has a very high chance of developing CVT compared to general population. Any inflammatory disorder has a high risk of venous thrombosis. So ulcerative or moderate headache for 6 weeks. I feel the best diagnosis should be CVT rather than IAH, because this is the most likely thing to be happen in such a history if the options are this. So that was this is a very difficult question. I don't know why they had given DSA image. Even if they shown an artery like IC or MC, it will be easy. This is something which has shown is a vein. They had shown what is this vein. What is this means? I don't know why they are asking such questions for an MD. Even a DM, you may not see that much DSA if you are not working in a hospital with angiography setup and stroke protocol. In stroke interventions are not there, you may not see much DSA images. So this is something which is, I feel it is a very difficult question, but with anatomical knowledge you may be able to answer. You knew that here comes your cavernous sinus will come somewhere here. The facial vein is located here. They ask what is this? So that is actually your superior ophthalmic vein. The superior ophthalmic vein, this is your superior ophthalmic vein which comes here, and you have other facial vein, angular vein, which everything joins to form superior ophthalmic vein, which drains to the cavernous sinus. So that was really tough question for me. So in the stroke, the 5 questions asked, these questions are not usual pattern, and there are one DSA which was very tough for me. I think it is very tough question. It is, I don't know why they have been asking such questions, but you can answer that if you have some anatomical knowledge. Then it was not that easy. Even superior cerebral artery, it was a bit tough. Then coming to spinal cord and MND, then we will move on to spinal cord and MND. So coming to spinal cord and MND, and somewhat like this, not exact thing, somewhat either of the picture, somewhat like this, a pattern of involvement is given, this area pain is lost. So this is a classical pattern which you see in a central cord, which we have discussed in our module. In a posterior column, you will have loss of vibrations and position sense below the level. When you have a lateral cord, you will have weakness with pain loss below the level. Anterior cord, again, you will have spared posterior column function where you have spared vibrations and positions, other sensations and power will be gone, because in the spinal cord, posterior part is controlled by vibration sense and position sense. Remaining here comes the lateral area has a pain and everything. So, when you use anterior cord lesion, you will have preserved posterior column. So, your posterior column sensation will be intact, while the lateral column sensation will be gone and power is gone. Where there is a pure posterior cord involvement, you will have power normal, pain normal, but posterior column sensation will be affected. So, the answer is a central cord. It's a cape neck pattern or shore like, west like or cape neck pattern classically seen in central cord, which we have discussed on module. So, this is rather very easy one. So, young male met with an accident and developed back pain with dissociative sensory loss, proprioception spared and has paraplegia and absent pain sensation below umbilicus. Again, this may looks confusing, but it is very easy. You go again in your clinical equipment, you go develop a back pain, dissociated sensory loss. Dissociated sensory loss means one sensation is preserved, other sensation is gone. With proprioception spared, that means the posterior part is spared and has paraplegia and absent pain sensation below umbilicus. So, the lesion is umbilicus means teton. So, it is a spinal cord involvement above teton, but posterior part is intact, that is anterior cord syndrome. Clear? That is as simple as that. So, if the Brown-Sequard syndrome, it is one side, the opposite side of the lesion, there is pain and temperature is gone, and other side the posterior column is gone. This is not like that. Posterior column is intact, that means anterior part is affected. So, that is a classical anterior cord syndrome, and the level is lesion is above teton. That is something which you can tell because paraplegia, upper limb is not affected. So, this is a complete cord transaction. This is something which we have discussed in module. This is a Brown-Sequard syndrome, and this is a posterior cord syndrome. There the posterior cord is affected, but anterior part is unaffected, where your dissociated sensory loss and weakness with preserved pain and loss of posterior column sensation. Here, you see have the anterior spinal lateral occlusion, which is a classical case where you have preserved vibration position sense, but weakness is there with loss of pain and temperature, dissociation is there. That is a classical anterior spinal lateral syndrome. Okay. Then coming next question, that is nusinersen is given by which I have specifically told during discussion, nusinersen is given intrathecally. We have discussed about the newer drugs, onaseminogen Provox, or which is given as IV, but nusinersen is given intrathecally. Something the same slide from our discussion. Only oral drug is risdiplam. I was telling that they may ask about a drug, but some different questions. Last time they asked about risdiplam. Okay. Which of the following muscle is not involved in Hirayama disease? This is also something which we have discussed in our other M&D session. Here Hirayama brachioradialis is not affected. Hirayama disease is because of it is like young male which present 18, which present with disproportionate because of disproportionate dural sac contents and vertebral column growth. This is a bone, and you have your dural sac lying here. This is a dural sac, and you have spinal cord lying here. When there is a disproportionate growth between the dural sac and the spinal cord during the growth phase, you may get dynamic compression. When you flex and extend, you may get compression at the cervical level. So, you will predominantly have a C5 to T1 involvement. Classical features oblique atrophy. The same figure which I had shown, I think I had shown in the during the presentation, where you have brachioradialis is paired, while other muscles are atrophied. That pattern of atrophy is known as oblique atrophy, which is classical of Hirayama disease. So, the muscle which is not involved is brachioradialis. CA-T1 muscles are affected. So, extensor digitorum, dorsal interossei, all these muscles are affected, but brachioradialis is preserved. There is a classical oblique atrophy of Hirayama disease. This also we have discussed in the module. So, M&D out of the 4 all were discussed, and I think most of the questions spinal cord and M&D were rather simple. And then coming to the miscellaneous area, there are 9 questions which is rather some areas overlap with toxicology, some areas overlap with other systems, but I had tried to put it all together under neurology. So, woman lit lamp in a closed room, somewhat like this. The question was somewhat like this. Woman lit a lamp in a closed room overnight and slept there and was brought to casualty with decreased sensorium and rigidity. You see, this is MRI. You see the hyperintensity in the globus pallidus bilaterally. So, this is the internal capsule, this is a caudate, this is lentiform nucleus, this is thalamus. Okay, thalamus, caudate, caudate. You see this image, this is a caudate nucleus, this is lentiform nucleus, this is thalamus. you can see hyperintensity here, that is nothing but the globus pallidus necrosis. So classically when the seen in carbon monoxide poisoning, when the woman has lit open the closed room over the night, you will have carbon monoxide buildup. This is again a question coming from toxicology and neurology together. Involvement around the globus pallidus classically seen in mitochondrial encephalopathies, also seen in cyanide, methanol, organophosphate, anoxia, as well as in your toxicity because of necrosis of globus pallidus can be seen also in carbon monoxide toxicity. Tonsillar pronation by pull mechanism. Normally the tonsillar herniation happens when the brain is pressure is increased, it pushed down the tonsils. Pull mechanism is where the CSF leak is there, hypotension develop. When you stand, the CSF is pulling down, the spinal CSF negative pressure is pulling down your tonsil, that is classically seen as CSF leak. This is also not a difficult question. Then coming to surface dyslexia is difficult to pronounce. I don't know what are the options given. This is something which I got from some candidates. I don't know exactly what are the options given. There are 4 types of dyslexias. I am not going into details of that, but rather you know that dyslexia where irregular words are difficult to pronounce. Irregular words. For a classical example is where you have kernel or yak. I have dyslexia. So I had this problem. When you try to pronounce or write kernel, it is written, if you read exactly like what it is written, if you try to pronounce it, colonel is something which you should pronounce. But it is irregularly written. That means it is phonemically and graphemically not matching. Graphemes and phonemes. Grapheme means what you are writing. Phoneme means what you are pronouncing. Usually when you write it the same way as it is pronounced. Here if you pronounce it in the exact way like what is written, you will pronounce it as colonel and yachet. But it is not like that. You pronounce it kernel. So that is what is known as irregular letters. So irregular word difficulty is known as surface dyslexia. I don't know what was exact other spellings given. So I think among these two, mint is something which is slightly irregular, but I think some more option might have been there. Kernel or yak are the classical examples where you have the written and phonological, the pronunciation doesn't match together. They are known as irregular words. Irregular words pronunciation is a classical feature of surface dyslexia, where deep dyslexia and phonological dyslexia, all these are difficult things for the MD level. These are different types of dyslexias, but classically this is a simple thing. Even though you don't need to know about the details of all those things, just this is something which is quite commonly coming dyslexias are the surface dyslexias. Okay. The next question was arsenic poisoning, which among the following is not true? This is also not a pure neurology question. Mees line develops over 6 months after exposure, causes rest-stop, CSF protein is elevated. Arsenic is known to produce rest-stop, arsenic causes Mees line, arsenic causes CSF protein raised. But the acute toxicity produces encephalopathy, GA symptoms, hypotension and vasomotor collapse. Acute and subacute will be symptomatic within 2 to 3 weeks, chronic within 1 to 2 weeks, Mees line develops within 2 to 6 weeks. So, Mees line doesn't develops at 6 months but develops at 6 weeks. So, that is a wrong statement. This is actually a bit tough, but I don't know how it was for other students. For me, it was a bit tough question. And the next question is, which among the following is false? High steppage gait classically seen in food drop. It is where you have food drop, you try to elevate and clear the food by elevating it. That is known as high steppage gait. Shuffling gait classically seen in Parkinsonism. Coercious gait. The coercious gait, you have the fear of fall. So whenever you have an imbalance, you will try to widen your base of the foot so as to adjust your center of gravity and reduce the fall, or then you will keep your hand like straight. All these maneuvers you are doing to maintain the center of gravity. That are things the body do to maintain center of gravity. So coercious gait, the patient feels falling, they will keep the foot wide. So wide base gait is classically seen in ataxia or any coercious gait, you will see a wide base. So that is a wrong statement. Coercious gait is not a narrow base, it is a wide based. Then Eagle syndrome, which cranial nerve is involved? This is also not a difficult question, but we have not discussed much about cranial nerve, but not a difficult question. Eagle syndrome is unilateral plane of the oropharynx face and earlobe because of compression of glossopharyngeal nerve, that is a nerve 9. So elongated styloid process and ossification of styloid head ligament, other causes. So this is not a difficult question, but rather this is a odd question, but you might have learned it during your MD entrance preparation. This is again a very deep neuroscience or physiology question, which I don't think many of you might have answered. And this is really tough question. Type 1 gray synapse, which among the following is true? There are two types of synapses classification by E.G. Gray 1959, type 1 and type 2. Type 1 synapses occurs are asymmetric, shows postsynaptic densities and predominantly excitatory. They are asymmetric, they are predominantly excitatory. Type 2 synapses are predominantly inhibitory and are symmetrical. But this doesn't stand now because some of the type 1 synapses are shown to be inhibitory, some of the type 2 synapses are shown to be excitatory. But type 1, according to morphologically, they are asymmetrical synapse, while type 2, they are symmetrical synapse. So, type 1 is asymmetrical, presynaptic membrane is complex, postsynaptic membrane is thick, asymmetric membrane differentiation. I think it is the asymmetric presynaptic membrane is the answer. Then coming to the next question, which of the following neurotransmitter is involved in the pain perception from nerve ending to DRG? I am not sure exact question was like this. So, what happens is the free nerve endings are there. They are stimulated by multiple mechanism. There are type A fibers, A delta fibers and C fibers. C fibers are stimulated, carry slow pain, while A fibers carries fast pain. The pain comes of free nerve endings. They goes upwards and goes to the dorsal root ganglion. Here the neurotransmitter which activates dorsal root ganglion either a glutamate of type A. Type A fibers has glutamate, type B fibers has substance P and glutamate. So, glutamate is a major neurotransmitter involved in the transmission. So, the answer is glutamate. The serotonin and GABA are involved in the modulation of pain. So, this is the, this you see the pain, this is normal pathways pain going up. Here you can see certain pathways coming down, that is a neuromodulatory pathways. These neuromodulatory pathways are predominantly serotonergic and noradrenergic pathways which are modulating this, and endorphins, all those things act in the modulating pathway. So, serotonin is a modulator, GABA is an inhibitor, so that is not the answer. Glutamate is the answer, which is glutamate and substance P are involved in the neurotransmitter. Substance P specifically for slow pain, that is a type C, and A delta fibers carries a fast pain via glutamate. Clear? So, there was one more question which came about meningitis, otitis media drug of choice. I don't know what was the options given. That is why I kept this question at the end. So, the organisms are like this, but in this is something which we have discussed in the module. This is classically which we give for any patient with pneumonia. If it is an adult, you will give third generation cephalosporin plus vancomycin as a drug of choice. But when it is with otitis, you should consider the possibility of anaerobes and you should add metronidazole also you can add. So, I think among the options, vancomycin, third generation cephalosporin plus or minus metronidazole is the best option. I don't know what options were given because otitis media, sinusitis and all those things you should consider possibility of anaerobes and can add a metronidazole also. That is what is given in the Bradley. So, that was about the questions. So, you had total 53 questions. Out of the 53, all the muscle questions, all the NMJ were difficult. Peripheral nerves were simple, demyelination was simple, movement disorder, one question regarding the Wilson's were tough, and dementia, one question regarding the sympathetic apraxia was tough. Cerebellum was easy. Epilepsy, I felt PNES question, and to an extent LGS, LKS, that is which among the following is less severe encephalopathy was little bit tough. Stroke, even though the questions looks easy, I felt 2-3 questions are really tough. Spinal cord MND was easier. Miscellaneous 1 or 2 questions are really tough. So, altogether it may be coming around the 13 to 15 or 16 questions were tougher about the 53. That means even though this looks a tough paper, around 70 to 75% questions you may be able to answer well. That is what, even though when you go through the question it looks tougher. If you start with a muscle, suppose you are getting the first question in muscle and NMJ, your confidence will be held down. Then you go and answer some question, it will be difficult. So, when you are attempting question papers, if you find a particular question is totally tough, you are not gone through that. Like muscle biopsy question, you have never touched muscle biopsy, you have no idea what is going here. Don't burn your brain on that. Leave that question and leave it from your brain totally. If you keep it in your brain, what happens is when you go on to the next question, you will feel okay, this is tough, this is tough, this is tough. Then you feel, oh, this exam is not for me. You should never take like that. Leave the tough question and then go to the simple question, then come back. You may be able to answer something. Like you see the peripheral, now there was one question regarding the lumbosacral plexus. That may looks very tough for you. If you are coming back from the muscle or NMJ and you go into that question with that mindset that is a tougher question, you go and try to answer, you will feel like that I am not able to get this question and this exam is not for me. That will be the thing that comes to you. So never do that. Even if your first question is tough, next question is tough, next question is tough, remaining questions are there. There may be some simple questions, leave those questions, and if you keep a free mind, you will be able to answer those questions. Even in a tough paper, you are able to answer at least 75% plus some guesswork, you may be able to answer a little bit more. So, and those, there are some questions like biopsy or some other questions which are DM level. There may be only one candidate or two candidates which will be able to answer it exactly what it is. So, leave that. That doesn't determine any marks or rank. Possibility of getting the rank value of that question is very less. So don't bother about that. Go for the easier ones, don't miss the easier ones. And if you have that mindset, you will be able to answer certain things. And second thing I want to tell you is that whenever there's a clinical question, don't go into the options first. Try to make up the clinical answer, then go to the option and the image. Then you will be able to easy to find out. The third thing is always keep your mind calm. Whenever you are in the exam hall, don't get frightened by tough questions, because the question for you will be there. And if you are prepared well, if you keep a mind calm, you will be able to arrive at some answers. And you will be able to guess something at least equally good. Like you are answering, you will be able to guess certain answers. Okay, so that was INA SS 2022, and each year the neuro part is getting tougher for INA as well as NEET. They are trying to increase the standard of questions, and some of the questions I feel that these questions might not have been asked because these are very high level, very high level. So that was about the INA SS. Thank you and study well.